Good morning, everyone. Welcome. I do expect a few more people to come on board. I know there's some people who couldn't make it, but I'm going to give it just another minute or so. What's kind of fun is I know all three of you that are here. I think I'm expecting about five more to actually show up today. So, while we're waiting, I think I kind of know where each one of you might be when it comes to the pause life, like what stage. But if you could just put in your chat, um, where you're at, okay, whether or not it's perimenopause, menopausal, or perimenopause, okay? So where are you at there? Just so I can kind of steer the conversation one way or the other, depending on what we have here. I think I kind of know, but if you could do that, that's one thing. The other thing is that, um, okay, someone's already put something in the Q&A, which is great. Okay, so any questions that you even have just now before I even start the meat and the potatoes of the webinar, go ahead and put any questions that you have in the Q&A. I may be answering them, obviously, as I go through things, but feel free to do that. Okay, so Carrie, you're Peri, which I kind of thought. I haven't talked to you in so long. Like, okay, how old is she? Okay, all right. Don, I think I know where you're at. Alex, I know where you are at. So, Don, I like your question. I'm not going to answer it right now. But the question was, have you seen bone loss in women during perimenopause? And the answer is yes. I am going to go ahead and get started here. So some of you do know that perimenopause and menopause is not for the faint of heart, right? And it's different for every woman. Some women definitely suffer more symptoms than others. So if you haven't reached it, which I know, Alex, you haven't yet, it can be very interesting and it can last a long time or it can be a short time. It just, again, it depends on the woman. It depends on a lot of different situations. So what I plan to do here is to go over just an overview of what's happening during perimenopause and menopause, and then looking at your questions and then answering some questions from clients that have sent him in email, and then also, the questions that I get in my clinic, I think can be very, very helpful. And since, you guys don't seem to be in menopause yet, I may kind of depend more on your questions towards the end here, focusing on that rather than on what's happening during menopause. But I think what's happening during menopause will be very helpful for you even now, okay? Just so you kind of know what to watch out for. So we got that. Some of the people who might be listening to this or might be listening to the recording don't know me. So let me introduce myself really briefly. I'm Cindy Dupuy. I'm a functional medicine practitioner, and I have been in private practice and in functional medicine for about 23 years now. I have focused until about 5 to 7 years ago. I have focused mainly on, well, actually, in functional medicine, you kind of focus on everything because everything's all related. But I guess gut health and then thyroid and then lab work as well, really educating people on the importance and helping people and supporting them that way and helping people become their own advocates. That's really important to me. And then I really moved into the perimenopause and menopause space about 5 to 7 years ago. And I did that for a couple of reasons. One is I was watching my own clients who had been with me, for quite a few years. So I knew how they ate, I knew their lifestyle, I knew that they were pretty dialed in, and we were still losing some ground here. And I thought, okay, in the past, I've kind of asked a cursory question or two just to see how they're doing. It's like, okay, how's your libido? And, any other complaints that they might have. And if they kind of felt like they were doing okay, then I would let it go. But the fact that we were losing some ground, I thought, I have to really look into this. The other impetus was that I was watching my contemporaries and watching how very different their experience was compared to my own experience. and other women I know who I know were on hormone replacement therapy. Now, this is not all about hormone replacement therapy, although we are talking a lot about that because I know a lot of people have questions surrounding that. There's so many other things that factor into moving into and through perimenopause and menopause. So watching my contemporaries, watching them go to the doctors, watching them become stiff and immobile and having a lot of health issues. And the other thing, I been in menopause almost 25 years, and I went into menopause at a fairly young age of 43. And I have been on HRT myself in some form or another for about 17 years. So I kind of know the terrain. So I was very interested in helping other women navigate this time in their lives, which is actually a very long time. Perimenopause and menopause in particular, is about at least 3 decades, we hope. Okay, depending on when you go into it. But 3 to 4, maybe even 5 for some women. Okay, so it's a long time, and we want to make sure that you're healthy and you're comfortable. So, also, along with talking a little bit about perimenopause and menopause in general and answering your questions, I will be talking about a course, and I know those of you who are on here are aware of it. It's called Grace in Transition, and it's for women of a certain age, and it's an 8-week course. I'll be talking more about that and then talking about how you can work with me as well. So, moving into the perimenopause and menopause space, just the overview. I do have a little slide deck to go with that. And so, perimenopause, all right, this typically happens between the ages of 40 and 50. Menopause typically average happens between the ages of, well, average is about 50, 51, but I'd say most women between 48 and 52. Of course, we can vary. And some women can actually start moving into perimenopause and may not even know it, younger than 40, but the average would be 40 to 50. During perimenopause, there's like 3 different stages, I would say, of perimenopause. So we have the beginning stages when progesterone really drops. That's probably the first thing that we're going to see. And then we have a second stage where perhaps our hormones are really being all over the place. Okay. So it's kind of like a roller coaster. And they call it the second puberty because that's kind of similar to what happens in your first puberty when your body is trying to figure out what the heck is going on. Periods can be very spaced, short, all over the place. So we're kind of retrograding here in a sense. The second part of perimenopause, again, can be when estrogen starts to drop a little bit more, okay, or even a lot, or we can have spikes and we can have drops, so that's all over the place. So we might need a little bit of estrogen support during that time, and then towards the end, we can become even more symptomatic. But again, every woman is very different. So, here are some of the signs and symptoms of perimenopause, and I put menopause too because some of these symptoms can be carried into menopause, depending again on the woman. They usually kind of level out, some of them, but some of them will stay. So, we'll have cycle changes, which I already mentioned, and that's irregular or skipped and periods, heavier or lighter bleeding, and then shorter or longer periods. And you kind of never know what you're going to get. All right, you can have vasomotor disruptions, so hot flashes and night sweats, and these may be intermittent. For some women, they are extremely disruptive and can interfere with life, especially if sleep is really being interfered with here because we have the night sweats and it's waking a woman up. We have sleep issues, and part of it, again, would be the vasomotor symptoms, and it can be because of the drop in progesterone, because progesterone can help mediate anxiety and can help with sleep as well. It works on our GABA neurotransmitters, so it helps to reduce anxiety and it helps us to sleep. Okay, that's what progesterone does so very nicely. We can have mood and cognition changes. So we can have irritability. We can have depression maybe for the first time or worsening of depression. We can have anxiety for the first time or worsening of anxiety. We can have the brain fog and forgetfulness is where we walk into a room and we don't know why we're there, or we can't have that word retrieval, which, you know, It's interesting the timing of this is like, really? It kind of sucks. Often women are kind of in their prime in their mid 40s. They're kind of reached the pinnacle as far as if they're working, if they're in the workforce, and then all of a sudden they have brain fog, they have forgetfulness, they have hot flashes, and they're maybe trying to give a meeting or something like that, and they're having a really hard time functioning. So there are many different ways of mediating all of these things. We can have physical changes. We can have breast tenderness can increase. We can have bloating, not just overall body bloating, but also issues with digestion can increase weight shifts and hair and skin changes. So we can start putting on weight that we can't seem to get off and maybe a little bit more of that belly fat. There's reasons for that. And then we can have sexual urogenital changes as well. So our libido often goes down here. And it's not necessarily a loss of testosterone. Our estrogen, um, really drives libido in both men and women. Our desire does, both men and women, and in women as well. Estrogen levels will drive satisfaction, so orgasm. So if a woman's estrogen is not high enough, that ability to achieve that can be reduced, and for some women, that can be an issue. And I also like to say when we're still ovulating, when we're in our fertile years, if you think about the time of the month when you kind of were maybe attacking your partner, it was when you were ovulating. So that's that spike in estrogen. The vaginal dryness is the drop in estrogen, okay, and that can be early signs again that you're really moving into that second part to third part of the perimenopause. You may have increased UTIs or UTIs for the first time, and part of that is because there's a change in tissue. And there's also a change in the bacteria when our estrogen and our progesterone's levels start to change. So that's really interesting as well. Some other things that go along with it is we can have fatigue, we can have joint aches, headaches, worsening PMS. We may find that allergies may increase because of histamine, and increased facial hair, and possibly losing hair. And then we can have like ringing in the ears. There's more symptoms that come along with that. And this is the deal. The deal is that we can unfortunately often start to see doctors trying to help their patients deal with many of these symptoms. And there are pharmaceuticals other than hormones out there that can alleviate vasomotor problems, that can, UTIs, they would be an antibiotic. The mood and cognition can be an antidepressant or anti-anxiety. So we start getting a little bit of polypharma during this time, right? Our cholesterol can go up, blood pressure may start going to go up as well. So, doctors are handing things out, and this is where that whole polypharma, which could really be a vicious circle, can start here. I do want to say one more thing, and that is I'm I'm very happy that a lot of bigger companies and government, okay, it's like city governments, I know in LA, they are recognizing that their perimenopausal and menopausal women do need to have support. And I think they've even allowed for more personal days, and it can be specifically to this time in their lives, which I think is absolutely fabulous, knowing that these women need to be supported. Now, the thing that I would like to see is more education so women know more of what they can do in this situation so that they don't necessarily need to take more days off. They're functioning much better in life. I would really like to see that. And kind of in the background of the slide, this is a roller coaster, and you can see two women, right, going down the roller coaster. One is laughing, having a great time. And one is like, get me off of this ride. And that's kind of how perimenopause and even menopause is for women. It's different what their body does, where they are in life, stress, thyroid, all these things play a role. Okay. And then you're in menopause, you've arrived. But the problem is sometimes you feel frazzled, frumpy, and fat. when you hit menopause. It doesn't have to be this way. So, how do you know you've arrived to menopause? It's kind of an arbitrary line in the sand, and it is when you haven't had a period for about a year, okay? And then all of a sudden you're in menopause. And the deal with that, or the problem with that, is that let's say you've gone 7 to 8 months without having a period, and all of a sudden you have a period, okay? Maybe two periods. Do you start again from that time? You've had a period just now and start that whole year again? No, you don't. And another thing you can do is, test your hormones, not just estrogen, progesterone, but LH and FSH, testing those as well, because those will really go up as we move closer and closer to menopause. So your hormones on tests at this point in time are a good measure. Prior to that, like if you're testing in perimenopause, your FSH and LH might be good indicators, but measuring estradiol and progesterone, they can often be so all over the place. It's really hard to get a good gauge of how close you are to menopause. But the FSH and LH, if you measure those, can get you there. So you've arrived, but maybe you're not feeling so great. The thing is that often when we have hit menopause, because you're no longer on this hormone roller coaster, you can feel your body calming down a little bit. You still may have, and I didn't talk about this, but you may have incontinence, urgency. You still may have a difficult time sleeping. Your cholesterol may have gone up higher. Your A1C might start going up a little bit higher as well. But that roller coaster and even that brain fog often will settle down. Okay. Now, I had mentioned that there's like three different phases of perimenopause. And through my own journey and with my journey with my women and my clinical practice, I'm watching that there's different stages too. And it's not only physiological, there's also an emotional part as well. And I would say the first stage of menopause would be within the first 5 to 10 years of menopause for most women. And again, for most women, that would be between 50 and 60 years. And I remember feeling in the first 10 years of menopause like I had the world by the tail. Okay. I felt strong. I felt good. I still felt like I was in the game. And I'm watching other women who are in this period and they are kind of on top of things. It's like it's fun to watch, actually. You still are often very physically fit. You have the energy, you have the muscle mass, you have all of that. Okay. So that's, and in fact, most of the people in the menopause, that's what they call themselves, and I'm pretty sure you guys know who they are. Dr. Mary Claire Haver, ah, who's the urologist? I love her. Who talks a lot about testosterone. And there's some other ones, but they're all in their 50s, okay? They're slaying it and they're in their 50s. And then I would say the second stage is probably somewhere between 62 to maybe your late 60s. And that's kind of a sweet spot or kind of moving into a different awareness. And then after that, it even moves into a different awareness. I don't think there's so much body changes so much in that third part, but just awareness and how you perceive life. So just a gentleness, just a softening begins to happen. And you are, and you become aware that you are in more the last decades of your life. There is an awareness of that in a way that I don't think we have prior to that. All right. So again, we're in menopause, we've arrived, and a lot of those symptoms have mellowed out, have gone away, and we're just kind of going along, and we kind of maybe breathe a sigh of relief. But I always like to remind women that, the symptoms are basically what we see above the surface, right, of the iceberg. But there's a lot of stuff that's going on below the surface that we're not seeing, that we don't detect until there is an event. Okay. So if there's a heart attack or a stroke, that's an event. All of a sudden we realize that, okay, we have cardiovascular disease. There's osteoporosis. Okay, it usually starts off as osteopenia, but then it goes into osteoporosis. And osteoporosis is often not diagnosed or tested for, unfortunately, until we're in our 60s. So I still get women coming in to me and they haven't had a DEXA scan. The doctor hasn't offered them one and they didn't know to ask for one. And they're, in their early to mid 60s. It's like, wait a minute, that is way too late. And I might as well get into the osteoporosis here in just a minute, okay? We can also have diabetes forming, okay, without knowing it because the doctors aren't testing the correct things. And we need insulin. I'm big on really good lab work for a very good reason because we have to monitor things like inflammatory markers. We have to monitor things like insulin. These are all the things that will indicate that we're moving towards cardiovascular disease or diabetes. And estrogen really plays a huge role in insulin sensitivity and metabolic resiliency and fitness. So I'm talking about the body's ability to be glucose sensitive, right? And then we have Alzheimer's dementia that, it doesn't begin in your 60s and 70s. It starts in your 40s and your 50s. And so again, we need to watch all of these things. I'm going to go back to osteoporosis and talk about that for just a second. So genetics does play a large piece, okay? There are some things that we're going to be genetically predisposed to than others, and then our lifestyle determines that as well. I think with osteoporosis, just from what I'm seeing, that is the case. I mean, lifestyle and diet and all of that plays a role. But the genetic component really does, perk up my ears as to how closely we need to monitor things. How early you've gone into menopause also perks up things. There are other risk factors that can contribute to early osteoporosis or onset of osteoporosis. And, I don't know how many of you know that I do have a YouTube channel, but I have a full YouTube episode specifically on osteoporosis because it's a big subject. So if you're curious to know about other risk factors, you might want to look at that. I do want to say this, and that is we lose the biggest amount of bone during the first 10 years of menopause. That's when we lose it. And so I always recommend trying to get a DEXA scan 45 or 40 to get kind of a baseline so you can catch what your body is doing. And then definitely get it and within the first couple of years of going into menopause. You can see the changes here and you can monitor it. All right. Now, DEXA scan is not an end all be all. It's not, but it's still the gold standard of what doctors use and what the insurance and medical world uses. I am going to mention some of the risks. So risk can be if you were an athlete growing up, okay, and maybe you weren't menstruating very regularly. So that's, you're not going to have much estrogen. Estrogen is what holds the bones in the density, okay? So osteoclast, break down bone, and estrogen prevents the activity of the osteoclast or slows it down. If you have been on steroids, so it can even be inhalers for asthma, that can be a risk. Again, we talked about genetics. If you've had digestive issues, if you are gluten intolerant or celiac, so your digestive system hasn't been working well. So these are some of the risk factors. So if you know what some of them are, maybe you can use them, right? Creating a story to get the labs that you need to get the DEXA scans that you need at a younger age, okay? Sometimes we have to do that. Okay, so it is really important to know that even though a lot of the symptoms that we experience during perimenopause have gone away once we hit menopause and during the first couple of years, we might feel like we're okay. We need to be aware of all these other things that are lurking below the surface. Okay. All right. These are some of the questions that I am going to go into because I think it's helpful. You may not even know that these should be questions. I know Dawn had a really good question. I think your question was, have I seen bone loss in women during peri? And if so, what do I recommend? Yes, I have seen that. And again, it could be some of these risk factors that I just mentioned. It could be something else. I know you're pretty active. So, of course, the first things that I would recommend would be to make sure you're getting enough protein, to make sure you're getting enough weight-bearing exercise, and that you're also putting a torque on your bones. So, twisting, turning, yoga, Tai Chi, balancing, things like that. Put a load on your bones, and that's really, really important. It's also really important because we want to stay agile as we get older. So, bone density is part of the picture, but also making sure that a person does not become fragile. So, that would be weight, that would be the ability to balance, that would be the ability to get up and down. So, fragility is a lot of different things. I do want to say this. I know that if you've ever gotten a full body composition test, right? So it's the machine that goes up and down, so measuring your body composition. They do give you a bone density score. So I want this to be very clear. That is different from a DEXA scan. That's specifically for bone mineral density. Okay. It can kind of be an adjunct, but it is not the gold standard. So the results that you get from that DEXA scan, specifically for body composition, don't stop there. Please have a formal, regular DEXA scan done. And if your physician won't do it, you can order it yourself. And in California, I think it is around, it may be as much as $100, maybe the tops would be 150. Okay. So the reasons, again, you've got risk factors. If your estrogen has hung kind of low, PCOS can also be another risk factor. If you've had PCOS and your body hasn't really been ovulating and you haven't had the bursts of estrogen and the bursts of progesterone, okay, that can be a risk factor too. So there can be a lot of different things. So while we're on this subject, so Dawn just mentioned, and I think all you can see that you've paid 75 and 150 for DEXA scans. 150 scan was more because it was the entire spine. Okay, yeah. You can also, by the way, DEXA scans, you can get a trabecular score, which is something. So DEXA scans look at your density. The trabecular looks at more of the composition of the bones. And not all of the labs have the ability to offer this, and I don't think there's an additional cost if theirs is very small. But if it was me and I was looking for a DEXA scan, a place that did it, I would ask them if they do the trabecular score as well and have them include that. All right. So this is a good time to talk about what you can do, right, for osteoporosis. Hopefully you're just seeing osteopenia. Okay, that's it. And hopefully through diet, lifestyle, putting the load on the bone, that can be helpful. If there's a propensity to have bone loss in your family, you may need something a little bit more. And interestingly enough, estrogen and HRT has been FDA approved to prevent bone loss in women. It was approved in 1985. And the interesting thing is not one woman who's come into my clinic who has significant bone loss has ever been offered estrogen. And there's a lot of reasons for that. The biggest reason is because of the WHI study that came out in 2002 that scared everyone, said it caused cancer, which they've backpedaled and dialed all of that back. They've dialed all these things back, but the damage was done. And for the last 3 decades, women have not been offered what they need to be offered as far as hormonal support. So it does prevent osteopenia and osteoporosis, and it is approved by the FDA. Again, right after the Women's Health Initiative in 2002, women dropped their HRT, doctors dropped their HRT, and then doctors were not taught about perimenopause and menopause or hormone replacement therapy since that time because they weren't going to use it. It was dangerous, right? So we don't have the support that we need. And the interesting thing is Boniva, which is a biphosphonate, which is what most doctors will reach for to help women decrease their bone loss, which it does do, but it has risk factors and side effects with that. Some of them significant. So Boniva biphosphonate, that was the big one that came out in 2003, a year after the results from the 2002 Women's Initiative study. And that became the big one there. So I would say make sure you have adequate amount of estradiol and perhaps even starting to take estradiol in perimenopause and doing all the lifestyle and dietary things as well. Some of the questions that come in, because I think that it's good for you guys to know. All right, and this can happen in perimenopause. Why can't I lose weight? I'm working out like a fiend and not eating much. And that often happens. And the reason being, it could be a multitude of reasons. It could be that you're not getting enough protein, you're actually working out too much, and your body's going into this kind of hibernation state in that it feels like it has to conserve energy, okay? Because you're not eating enough and you're working out too much. That can happen. The other thing that could be happening too is often thyroid changes in perimenopause. So if you've already like Hashimoto's hypothyroidism and you're taking medication, when we have a drop in progesterone, that can really affect the body's ability to convert T4, which is a non-active thyroid hormone, into the active form T3. That can really play a role here. And often we also have a more inflammation during this time that starts to heat up. And again, estradiol and progesterone both reduce inflammation. So that starts to go out the window. And those can play a role on your antibodies. So if you have Hashimoto's, that can raise the antibodies. So it's really, really important always, but in particular during perimenopause, to have really good lab. And that is something that I do in my clinic. I can order lab work for you. I look at lab work before and after, and I put it all together and help guide you to do the things and ask for the things that you need in order to support yourselves. Okay. So this is a big question. Why has my cholesterol gone up? Your cholesterol goes up as your hormones go down because cholesterol is the backbone of your hormones. So if your hormones are dropping, your body still wants to make these hormones. They do. It's just that they don't have the follicles to do that anymore. But they're going to do whatever they can. So that's one reason. Another reason is, again, our inflammation will start to go up. And our LDL, our bad cholesterol, also raises in response to inflammation. So those are the two reasons. And it's really funny. It's I'll see a woman come in and her doctor's concerned about her cholesterol. And so, they want to put her on a statin, which is like, no. Statins do not effectively prevent cardiovascular disease or heart attack, by the way. And there's a lot of side effects with women, men and women, but women in particular. So where was I going with that? Instead of doing a statin, right, I will recommend that my client go on some estrogen and we watch that cholesterol go whoop, down like this. So, it's there in black and white. Okay. Why do I have so many aches and pains? Well, here again, it's interesting because as we lose our hormones, especially estradiol, it affects every single organ and tissue in our bodies, including our our joints, including our ligaments. And we think about that padding in our joints, the gel that's there, the collagen that's there, that matrix that's there. So when the estrogen starts to go away, again, depending on the person, we just don't have that cushioning that we had before. And the inflammation, again, also goes up. So there's a lot of different things that are going on to play that role. My doctor told me I can't take hormones because there's cancer in my family. This doctor is not educated, okay? And you heard me say that doctors have not been educated in the last 3 decades in medical school about perimenopause or menopause and about HRT. It went out the window. So unless a doctor is seeking out specific courses in perimenopause, menopause, and HRT, okay, outside of the basic realm here that they normally are exposed to, they are not going to know what to do. They are not going to be up to date. And in mainstream medicine, their continuing education still too much relies and falls back on the Women's Health Initiative study and the results that came out 30 years ago, which they again have backpedaled so much since then. So, if there's cancer in your family, it does not mean that you're going to get cancer, all right? So that doctor does not know the lifestyle or the diet or the drinking patterns or the exercise patterns or anything else, okay? They haven't asked you that. I guarantee you that, all right? And what is your lifestyle like? Have they asked you that? Okay, so just to blanket say you can't do it is wrong, all right? I have people in my family who have had cancer. It doesn't worry me. And even if you have had cancer, right? Even if it is hormone driven, you still need to know the risks and the benefits of estrogen and progesterone, okay? For you to decide whether or not, depending on what your symptoms are, depending on what your life is like, whether or not it is right for you and you would like to try it. So if you've never had cancer before and the doctor shuts you down because there's cancer in your family, go find another doctor who will listen to you, okay? Who is open if it's something that you want. This is a very individualized thing, okay? Taking hormone replacement therapy or not. And some women really get hit hard with the symptoms that I talked about before, and some don't. Okay, and that's fine. And if you are going along your life, and if you're not on polypharmacy and your labs look good and you're feeling good, then you're doing great. There's nothing that we need to fix. I just don't see that very often, to be honest with you. Okay, we already went over. I'm worried about osteoporosis. What's the best way to prevent it? My doctor is worried about giving me estrogen because of history of stroke in my family. She wants to put me on testosterone instead. What are your thoughts? Okay, so this is from a client who actually came into my office, and she was around 67. She hadn't been on any type of HRT before. Now, it is super hard to find doctors who are willing to put a woman on hormone replacement therapy if she is 10 years outside of when she went into menopause. And there's a misnomer with this. When they first started to come back and say, you know what, I think we were wrong with the Women's Health Initiative study. We think that hormones are probably okay. They came back with, okay, we're going to put women on the lowest dose for the shortest amount of time. And so that was about 10 years. And if a woman does not go on hormone replacement therapy within the first 10 years, we are definitely not going to put her on HRT after that. Okay. She's already passed that fine line. All the benefits that estrogen and progesterone give her somehow vanish when she gets older. I don't know how that happens. So the deal with stroke, it's interesting. The WHI study actually was in conjunction originally with the American Heart Association. So they were trying to also see if HRT did reduce the frequency of heart disease. And in case you don't know, heart disease is the number one killer postmenopausal women, not cancer, not anything else. It's cardiovascular disease. So once we lose our hormones, all of a sudden we catch up and surpass men in deaths and cardiovascular disease once we have lost our hormones. So our hormones, again, are very protective. So what they found was that if you take hormones within the first 10 years of going into menopause, it is heart protective. All right. If you start hormones after that 10-year period, it is not necessarily heart protective anymore, okay? And it cannot reverse the damage that's done. So let's say, during the first 10 years you weren't on HRT and you've developed some plaque or you've developed some inflammation in your heart or something's going on here. It probably won't reverse that, all right? But what it will do, first of all, it won't make it worse, okay? And I'll tell you why. And what type of hormone replacement to take. But It will probably reduce the inflammatory markers, will probably make you more insulin sensitive. So the whole metabolic problem that we have, okay, with glucose and diabetes and all of that, as we get older, that will probably be contained much better. And it's that inflammation that drives cardiovascular disease. It's not cholesterol, it's not that, it's the inflammation. So if we're on HRT, it reduces the inflammation. And again, it helps with weight, which all contribute to cardiovascular disease. Okay, this is a long answer to this question. Oh, the type of estrogen or progesterone also makes a huge difference. Okay, so in the Women's Health Initiative, they gave women horses equine urine. Okay, so estrogen made from that. Definitely not bioidentical, number one. And they also gave the women a progestin, which is not a progesterone. Okay, two very different things. It sounds similar, but it's very different. And they gave the estrogen orally. Now, there is just a very slight higher risk of estrogen orally causing clots. So, would I give a woman estrogen orally? There's absolutely no reason, in my opinion, to ever give a woman estrogen orally. There are so many different ways of giving estrogen to a woman. It can be transdermally, through a patch, through creams, through gel. It can be an injection. So transdermally would be my first choice. It could be a pellet too. Okay. So there's really no reason for oral, which has to go through the liver pass. Okay. It has to go through the digestion and the liver pass. And that's what can cause it. So let's go back to the testosterone. This woman's doctor was very caring. This woman had been with her doctor for a long time, so definitely trusted her. And I could tell just from the interaction and just from the conversation that was relayed to me that this doctor was doing the best that she could do and was looking out for her patient. So, what happens when a woman is put on testosterone? How does that help? Now, testosterone is still not FDA approved for women in the US. It is approved in the United Kingdom. It's approved in Australia, New Zealand. There might be one other country, maybe Canada. I don't know. But it's not in the US. So it has to be used off label or it needs to be compounded. And in all those other countries, testosterone is only given to improve libido. Really? There's so many other benefits we get from testosterone. Not every woman needs it, but there's so many other benefits we get from testosterone. Now, the reason why this doctor did put her on testosterone, the thinking that she had, and testosterone, by the way, can help with bone buildup. Okay, so I do suggest it to some of my clients. It can help with moods. It can help with muscle mass, which helps again with diabetes, which helps with weight gain and all of those things. So there can be benefit from testosterone. And our bodies can also turn some of that testosterone into estrogen, but it's more of the estrone that it turns it into through an enzyme. So you're not going to get the level, it just doesn't convert. You're not going to get the protective level that you would from taking HRT, from taking estrogen, just by giving testosterone. Okay, so it's a stopgap. I need to follow up to see how she's doing. I really like to know. We learn a lot in our clinics just by what our clients do and what their experiences are. So I think that was a stopgap. I think probably she would have benefited from getting the estrogen, and I don't think there needed to be a caution around it. All right, these are for my older ladies. I know you guys aren't older, but if you run into a lady or you've got your moms or whatever, okay? I'm 73 years old and my doctor told me I'm too old to go on hormones. Is that true? Again, I kind of gave you the background of how after the Women's Health Initiative, they said, the lowest amount and for the shortest period of time. And again, I don't know how anyone can think that taking a woman off of estrogen is going to all of a sudden magically all the symptoms that she was preventing, how that's going to continue to go on. All right. So the answer is no, you're never too old. Now, I just ran into this myself. And I've been on hormones for 17 years and I've done well with it, right? I mean, I'm not on any other prescriptions, whereas you look at a woman my age, and most women are. And this cute little young doctor who's very caring. I don't know if we're going to be able to work with each other, but she's very caring. I could sense that. She wanted me to go off my hormones, and she's looking at me. She goes, "I know you're not going to." I said, "No, there's no reason to." I said, "Have you looked at the, statement that was put out by the North American Menopause Society in 2022? Because it's very clear that they are saying, do not take your women off of it, okay?" And she said no, but ACOG, which is the Association for OBGYNs and gynecology. So, of course, I put together something that she will get from me. But anyway, it is harder to be put on HRT after you haven't had it for years. And there is a reason for that. And I get it. So you have to go slow and be cautious. Look at the inflammatory markers, look at the symptoms, and really guide your woman through it. And again, starting really, really slow, because those estrogen receptors have been quiet for a really, really, really long time. And so you don't want to bombard things. If I'm not experiencing any symptoms of menopause, should I still take HRT? That is up to you. And I will go back and refer to that iceberg. Okay, what's going below the surface here. When is a good time to start HRT? This is where my perimenopausal women can come into play here. It depends. There are some doctors who will start their patients on hormone replacement therapy as they're going through menopause, and I think that's great. But there's a caveat here. I've also seen women being put on HRT where actually they needed their lifestyle attended to, they needed their thyroid attended to, and because thyroid and lifestyle can mask sometimes what's happening with hormones. So again, you need a complete workup. You don't just reach for HRT. Again, the progesterone drops first, so often I will reach for progesterone or reach for an herb like Vitex to boost it up, or even maca to boost it up. And then symptomatically, if someone's really starting to find, depression, anxiety, things like that, then, we might want to top things off with estrogen. And you can get some really high quality estrogen over the counter. I like Karen Martell's and I like Anna Cabeca's products. And you can kind of top things off and smooth things out a little bit. Okay, does Medicare cover HRT? It will. It will cover patches and it will cover oral progesterone. It will not cover creams that are compounded in pharmacies or pellets. Is it safe to take vaginal estrogen after cancer? The answer is yes. Vaginal estrogen is just local and it is so beneficial. I mean, I see so many of my older women coming in with repeated UTIs, and they get antibiotics. It screws up their whole digestive system and the whole tissue around the vaginal area, and then the pelvic floor too. Okay, so we have incontinence, the pelvic floor, it keeps it all healthy, and that is huge. So that local vaginal estrogen is not systemic, and I would say that I don't know what the percentage is, but more and more oncologists are beginning to realize that, as well as gynecologists. So there is a shift in that, and I'm so grateful for that. I know there was a question or a comment here. Don says, stay on hormones. Okay, let me just see if there's one more here. Okay. I've talked a lot about HRT, and to me, it's very beneficial, but it is just the icing on the cake. So just like you can't supplement your way out of bad diet or lifestyle, you can't HRT your way out of, or medicate your way out of a bad lifestyle or nutrition or anything like that, or gut health. Gut health's huge, and then exposure to environmental toxins. So it's not like a magic wand. And I like to get all of these other things in place actually before I put a woman on HRT. The thing is, that doesn't always work. Sometimes women are just in such bad shape that they can't even put the other things together, what I've got up here together because they're feeling so badly. So giving them a little HRT and then working on these often is what will have to happen, especially if she's kind of further down the road in menopause or she's having a really tough time during perimenopause. But often during perimenopause, what I'm finding is it's thyroid and it's nutrition and lifestyle and gut health and environment and adrenal health that's driving more of the more exaggerated symptoms in a lot of perimenopausal women. So this is super important. You cannot ignore any of that. And that is why I have created my course, Women of a Certain Age, Grace in Transition. It is an 8-week course, so it's kind of long, I know. So I go over everything. It's very extensive. You get my expertise, you get access to me weekly, and then through the chat box, we have menus, recipes. There's a daily movement accountability group, and you have me as a coach with that. You get 3 different course handbooks, which are very valuable. You get videos, get 20% discount on supplements, and opportunity to work with me one-on-one at 30% off. And it's $247. The next session is actually starting February 2nd, which is in a couple weeks, but that enrollment has closed. So I will be offering it again in April 6th, which is a long ways away. I know that. But if someone wants to sign up and make sure they get a spot, because it's limited, I only take 12, I'm pushing it at 15 women just to keep it intimate because I think the community part is really important. If someone wants to get started, if you do enroll, you have access to a big portion of the material right when you enroll, and then you get everything else when the actual course starts. The other ways of working with me, probably the easiest and lowest price point would be a lab and supplement review where you send me your labs, I look at them, I talk to you, I recommend some more labs, and then we go over everything, a very complete lab workup and supplements, and then I look at what you eat, history, all of that, and then I come up with a protocol for you. So I think that's $197. Go to my website. It's a livingbalance.net. I should know how much I'm charging, right? But at livingbalance.net right here, you'll see all of that on the homepage. And then the ALB package includes 5 sessions with me. So if you need to, work through some issues, then you probably want to do that. And then I offer labs and I can order them. And again, I would do the labs, the review, the consultation. So that would all be included in one price. And I have specific packages for perimenopausal and menopausal women. So that's pretty much it. But the reason why I'm doing what I'm doing is because I want women to enjoy life to the very, very end. I don't want to see women at doctor's offices all the time. I don't want to see them hobbling. I want them to enjoy their lives, whatever that means to them. And I want you all to stay independent. And we have to educate ourselves. We have to know how to advocate for ourselves in order to do that. And we do need a team. We do need a village. We do need a second pair of eyes. I mean, even me, and I know a lot, I can get intimidated in front of a doctor. Okay, if something comes up and they tell me do something, I have to step back. Okay, and I have to do my research and I get intimidated sometimes too. Okay. So having someone else in your court can be really valuable. I am going to stop sharing. And if you have any more questions, please don't be shy. Put them up here right now so that I can answer them. Recommendations for non-existent libido. So it could be testosterone. Okay, you might need testosterone. I would check for estrogen levels as well and kind of see how close you are to menopause. Estrogen is a big one for libido. Testosterone is definitely a big one too. And every woman is different. And each woman has just genetically has different abilities to absorb or be receptive to testosterone. And I just learned this just recently, by the way. Men do too. I can have some women that come in, and myself included. I mean, my testosterone always looks low, all right? I don't have a problem with libido per se, most of the time. Although it has definitely changed, but I'm older than all you guys, all right? So I think my receptor sites are really open to the testosterone that I have. Now, having said that, we are still kind of at the lowest dose estrogen. Doctors are still there, even though they're willing to prescribe estrogen. So I will still see fairly low blood levels of estrogen, and I'm all for testing your estrogen, your hormone levels. I think it's super important to know whether or not your body is absorbing the type of hormone replacement that you're taking. Some people are super absorbers, some people don't absorb very well. I have a client that we kept on going up, and it's like, okay, we gotta do pellets, we gotta do an injection, we gotta do something because your body's not absorbing it. Okay. So that can happen. And we want to see estrogen levels at least 50. That's where we get protectiveness. And even up to 150. And there's going to be some doctors that go, oh no, not 150. And the thing is that when we were in our fertile years, our estrogen went up to 7, 800, 900 when we were ovulating. Okay. So 150 is not that high, and each woman is a little bit different. I will tell you this. If your estrogen levels are not up high enough, because they are that driver with libido, even more so than testosterone in some women, okay? And I've experienced that too. If it's not high enough, you're not going to have the libido and you're not going to be able to achieve orgasm. Okay, so the interest kind of goes away. What can we do to help with absorption? You can move, either if you're doing a patch, you can get a different patch, a different brand. Okay, that can sometimes make a difference. You can move where you're putting it. Um, if you're putting it on a really fleshy part, you might want to move it to, well, if you're doing a cream or a gel, you might want to move it to more the inside of your arm. If you're not absorbing it there, you want to move it to a fleshy part. You can play with it. Okay. In fact, I recommend you playing with it. If you're still finding that you're not absorbing it, then you might want to go to either injection or a pellet, but start low dose on the pellet and have it tested. Okay, monitor it. Okay, so Carrie, I hope that helped you with that. And Don, with absorption, everyone's different. Everyone's very, very different. I'm a hyper absorber. I've only done the compounded creams, but I went way up there. I hope that helps you. If you have any more questions, just email me, okay? And I'm happy to answer them. I'm glad you're curious. I'm glad you guys were here. I'm glad you're taking care of yourselves. And I'm sure our paths will continue to cross, and you all take care, all right? All right, with that, I will see y'all later. And yes, please share it. Thank you so much. Bye-bye.